Dr. Margetis, Associate Professor of Neurosurgery, Orthopedics, Rehab, a spine surgeon in our department, Director of Complex Spine Surgery at Mount Sinai Hospital, and Director of Spine at Union Square. Trained in Greece. I introduced you a couple weeks ago, Con, so I'll be very brief. Did his fellowships at Cornell and Cleveland Clinic before coming here. And then we have Jeremy Steinberger, who as Director of Minimally Invasive Spine Surgery in the department, and completed his training here at Sinai, followed by a fellowship at HSS in orthopedic spine surgery. And they're going to be jointly talking to us today about endoscopic spine surgery, the future, question mark.
Thank you, Peter. Okay, can you see my screen?
Yeah, we can.
Okay, perfect. So I'll start. A couple of years ago, I had busy office hours, and I went in to see a patient without taking the charts before. And as I was waiting for Epic to log in, the patient told me that she had back surgery and that she was doing well. And I went on to examine her. So I checked the back, and there was a moment of confusion for me because I couldn't see any scar. The patient, I remember that I did surgery. The patient was telling me that she had surgery, but I couldn't see any scar. The only thing I could see was this skin discoloration here. And actually here on this photo, it looks much more pronounced than it was on the naked eye because of the iPhone sharpness function. So that's the type of scar, let's say. That's the type of incision that you typically see after endoscopic spine surgery. I mean, arguably the matrix incision is also very, very small, but again, you can still see an incision with matrix, while with the endoscope, as I said, you know, there's no scar there, there's nothing. So I think that's as minimally invasive as surgery can be. So what is endoscopic spine surgery? So basically we use the endoscope similar to what they use in intraventricular endoscopy. We do like a 7 or 10 millimeter stab incision. And we work under constant irrigation. So that's a little bit different compared with the endonasal transsphenoidal, where you're working in the air medium. So here you're working in a liquid medium. And that actually has some challenges because if you have any bleeding, then it obscures your field of view. And there are two main schools of thought, the uniportal versus the biportal. The uniportal is you do only one incision. The biportal, you do 2 incisions. I'm definitely like more like a purist, so I only do like the uniportal. I don't like the idea of doing 2 incisions, but for example, in Korea, where endoscopic spine surgery is much more popular, they're like 50-50, 50% they do uniportal, 50% of them doing biportal. So they're both like valid options, valid techniques. And for the equipment, we use the dilator, where this is the first instrument we insert in our target. Then we put the cannula over it, and then we withdraw the dilator, and then we put the endoscope in. So there are 2 main approaches to use the endoscope in the lumbar spine, the interlaminar approach. And here, I mean, we have like the 4 zones of stenosis, the central, lateral recess, foraminal, and far lateral. So if you do this approach, you can definitely decompress the lateral recess. You can definitely decompress centrally or do a discectomy. And you can also reach across and do like a bilateral, unilateral laminotomy for bilateral decompression. So basically here you undercut the spinous process at the contralateral lamina, and you achieve decompression as far laterally as the contralateral lateral recess. And you can also reach across and do foraminal decompression on the opposite side. There are some limitations on doing an ipsilateral foraminal decompression, and that was not described in this classification scheme by AO Spine, but here we have been able to do that by using the articulating drill bit that I'll show you a little bit later. That's something we haven't published, probably with SULD. And over here, I would like to show you that, you know, when you do a laminectomy, usually you remove the bone that is within the purple dots, okay? When you're doing a discectomy, usually you do a laminotomy like similar to the green area here. But when you're using the endoscope, that's the diameter of the endoscope. And for L4, L5, or L5S1, that you have a bigger interlaminar space, sometimes you don't even need to do any kind of bony work. You just dock it there, resect part of the flavum, and then you enter the canal. And if you're doing a lateral recess bone decompression, this is the area that you dock the scope, and that's usually a landmark that you can easily pinpoint and then start doing the bone decompression. So an important maneuver when you're doing interlaminar discectomy is the rotate to retract maneuver. So in the uniportal, you only have like one instrument. You cannot have like a bimanual manipulation of the tissue. So you need to find a way to retract the fecal sac. And what we do is we put the cannula inside the canal, and we have the deep end of the cannula laterally, and then we rotate it, and basically the deep end of the cannula acts as a retractor for the fecal sac, and we can access the pathology. So let's see a video of that. So over here is the fecal sac and or the nerve root, the shoulder of the nerve root, and here we're dissecting in the lateral epidural space. We have this dissecting instrument, and this here is the deep end of the cannula. Okay, we have advanced all the way down to the annulus, and now we rotate it, and by rotating, we're gonna retract the nerve medially, and our pathology comes directly in our field of view, and now it's very, very easy to just resect it with micro pituitary rogures. And once we're done with the decompression, we check the nerve to make sure that we have not injured the nerve, and you can see that the nerve retains its pink, light purple color, so there was no injury to the nerve. So the second approach is the transforaminal, and before we go into that, we need to review really quickly what is the Campbell's triangle. So basically, the Campbell's triangle is that area between the exiting nerve root, the traversing nerve root, and the superior end plate. And although we call it a triangle, in reality, it's a little bit more complex case because you also have the bony anatomy, you also have the superior articulate process over there and part of the pedicle if you go over here. So it's a little bit more complex, but for simplicity purposes, we like to call it a triangle. And although, in anatomic specimens and in cadavers, it is a true triangle, but in clinical cases where you have facet hypertrophy, it's more like a slit-like space. So over here is the exiting nerve root. Here is the bone, the facet. And in this case, this is the Campbell's triangle. So it's not really a triangle. It's more like, again, like a slit-like space. And that presents some challenges in the endoscopic transforaminal decompression. So if you try to fit the endoscope over here, most likely you're going to injure that nerve. So before you try to fit it there, you need to do some bony decompression. And I'll get back to that because that can be a limitation in the endoscopic transforaminal approach. So with the endoscopic transforaminal approach, you approach the spine in oblique angle and you target the pathology, and you can address a far lateral disc herniation. You can address a foraminal disc herniation or foraminal stenosis from bony hypertrophy, and you can go as medial as in the lateral recess to decompress the traversing nerve root or part of the fecal sac. Now, in terms of where you're going to dock, here's the exiting nerve root. Here's the facet joint that you definitely need to preserve that bone to minimize the risk for iatrogenic instability. And there are three schools of thought. One is to dock it at the superior articulate process. The other is to dock it at the disc space, or what I usually do, I start from this point here, the junction of the transverse process and the lateral facet. That's a landmark that you can very easily palpate with a dilator. And then I start from there and then advance the endoscope a little bit deeper. And I retract the nerve root as I do that. So let's see a case of transforaminal decompression. So you can see here, there's a foraminal disc herniation. And, you can do that by using a matrix tube and approaching the spine like that. But, you usually need to use a very long tube, or in some cases of higher BMI, the tube will not reach all the way down there. So this is not really a pathology that is very easy to treat. But with the endoscope, regardless of the BMI, regardless of how thick the patient is, once you dock it, the visualization is the same, regardless the BMI is 20 or 50. So let's see that. So here we have docked the dilator over the disc. And now we start the dissection. And we're using this cautery that looks like a bovie, but it is a bipolar. It has two poles at the very tip. And as we dissect, you'll start seeing a structure to come into our field of view. I believe this was the dorsal ramus. That's the nerve that the pain doctors ablate or they block when they do the medial bundle branch blocks. So we're going to sacrifice that nerve that innervates the facet, and it's actually usually innervates like pain-sensitive structure. So in regards to anatomy, here's the dorsal ramus. Here is the exiting L3 nerve root that we need to protect. The pathology is over there, and here's medial, here's cranial. Okay. So here we sacrifice the nerve because it was, in our way. Again, this is a nerve that is very, very small. It looks very big here, but it's very, very tiny. And that's the nerve that, again, the pain doctors very usually sacrifice or ablate in their procedures. So over here, we use the bovie to shrink the tissue and delineate a little bit better the pathology, the disc herniation. And the deep end of the cannula is over here where the nerve is, to protect the nerve from our actions. So we rotate to inspect the nerve, and here is the exiting nerve root covered by a little bit of fat and venous plexus. It looks good. It was not confused or injured by our actions. And now we're going back to the pathology. And all that is the disc herniation that we remove. Okay, so this is just a confirmatory X-ray that we were where we need to be. And at the end of the case, we actually had to resect some of the osteophytes, and we used the diamond drill bit for that purpose. The diamond is helpful because it can control the bone bleeding versus a cutting drill bit that can steer bony bleeding. And as you can see here, when we're drilling, the whole visualization gets blurry. That's from the bone dust that we create when we're effectively drilling. All right. So there is plenty of evidence about the advantages of endoscopic, especially discectomy. And now we'll also discuss about the endoscopic fusion. So the first step is to dock the endoscope like in a transforaminal approach, and we use some specialized instruments because you need to feed the instruments through the cannula, which is like 7 millimeters wide. You cannot use the usual disc saver. So we use this expandable disc saver, and we also use this articulating curette to do the initial disc space preparation. And we also use this articulating drill bit, and we use some kind of expandable cages. There are many out in the market. I will discuss a little bit later about the challenge that we have with this technology. So let's see this case, unstable spondylolisthesis. And we did the initial disc space preparation, and then we went with the endoscope inside the disc space. So what I would like you to see is that although we did the disc space preparation and it felt good, but once we went into the disc space, there is still a ton of disc. And especially there's still like cartilage covering the end plates. And, even if there's like a very thin layer of cartilage, that would be a barrier for our fusion. The osteoprogenital cells will not magically penetrate the cartilage to get into the bone graft and to get into the adjacent end plate to achieve a fusion. So what we need to do is we use the drill bit, and we remove part of the cartilage. And you can see here, this is a little bit of bleeding bone. That's the bone surface that will fuse. You see here the bleeding bone. So we were able to achieve a very, very good preparation. And here we're working the facet joint. And again, we're cleaning the soft tissue, and we're going to drill inside the facet joint to achieve also facet fusion there. And here are the post-op X-rays with expandable cage and the percutaneous screws. So, that's not something new for us. Our first endoscopic discectomy was 9 years ago. The first away case, 8 years ago. The first fusion was 6 years ago. And to the best of our knowledge, these were also the first for the city, not just for our system. So we do have like a lot of experience over the years with endoscopic spine surgery. We have published some of our experience, for example, the facet fusion. and also the resection of the coccyx, where actually the endoscope can be very advantageous because this operation is notorious for having wound complications and having like a 7mm incision versus, even with the metrics, like a 14mm incision can make a big difference for the patient. So overall, what are the advantages of doing an endoscopic spine surgery? So in selected cases, and I want to really emphasize that they can be much, much shorter. So for this transforaminal discectomy, once you dock the endoscope in the right place, you can be done like literally like in 15 minutes with the operation. There is potential to do the surgeries under back, but again, patient selection is critical here because if you need to do a lot of nerve manipulation, as we have found out, this can be very, very challenging. The patient will still feel that and will start moving, and you don't want the patient to be moving with the endoscope right next to the thecal sac. There's potential for less epidural scarring because you are much more targeted in when you're addressing the pathology. You need to do much less bony work, for example. The incisions, as we said, they're very, very small. Most of these operations, if not all, are ambulatory surgery cases. The ABL is minimal, and usually the opioids that patients need is definitely, the need for opioids is definitely decreased compared with other types of cases. But there are several challenges in using the endoscope. So when you go in, the diameter of the operative field is only 7mm. So sometimes you can get lost. You don't know exactly where you are. You just see bone and you don't know where you are. And you might need to get more frequently x-rays. And something that's a little bit disappointing is that we don't have like a good integration with the navigation systems. We try to improvise by clamping the navigation frame on the endoscope, but there's always some play in that, junction between the reference frame and the endoscope, and it's not as precise as we like it to be. Then another challenge that even if you have a small amount of bleeding, you lose visualization, and the same happens when you're effectively drilling the bone. So you need to stop, let the field clean and then continue. So that can slow you down when you need to do a lot of bony work. You cannot use by manual manipulation, especially the uniportal technique. In the biportal, this has been partially addressed, but the biportal is more for the interlaminar approach. It's not as effective for the transforaminal approach. And you work much more slowly in the bone because usually you use the diamond drill bit because the cutting drill bit creates too much bleeding. And there's a new technology they have adapted the bone scalpel to use through the scope. That's something that came up over the last few months, and I can't wait to get my hands on it and try it in a real case. But that definitely has potential to help us with the bony work, which is again currently a limitation by using the endoscope. We don't have an ideal expandable case. I've tried most of them, and it's not that they're bad. You can definitely use them, but I can definitely see their limitations. They can be either flimsy, or some others that don't really have very good structural support, or others that need very big cannulas to put them in. And also, we don't have a powerful technique to open up the disc space. When you're doing an open case, then you can put a laminar spreader, open up the disc, and move away the nerve from the area that you're working and make the operation much safer. And we don't currently have that for endoscopic cases or for MIS cases. And also you need to hold the endoscope, and that can create definitely some hand fatigue. Or if you have the screen, if you don't have the screen exactly opposite on you on the operating table, then you need to work with your head and neck rotated, and that can definitely lead to neck fatigue. So what are the ideal cases to use the endoscope? I think that any foraminal or faralateral disc above L5, in L5 is a little bit difficult to get that oblique trajectory. The iliac crest might get into your way, or the facet might be covering most of the pathology. But for L4, 5 and above, it can definitely be very, very effective. And you can do the case really, really fast. If you have isolated lateral stenosis, you can also very easily do that with the endoscope. And if you have L4, 5, L5, S1 paracentral discs that have not migrated more cranially or more caudal, so if they're like exactly at the disc space level, then you can also very easily address them with the endoscope. And disadvantages become more significant when you're dealing with high BMI patients, where even docking a tube might be challenging. You might need to do a cut down because the tube will not reach all the way down. Or, you need to work through a very, very long matrix tube, like 9 centimeters, 10 centimeters, and that's not really that easy. Also, in discitis cases, instead of sending the patient to get a biopsy by IR, you can go with endoscope inside the disc space and get enough sample and do a very, very thorough cleaning of the disc space from the infection. And in regards to fusion cases, I will consider a case where the Cambrig's triangle is open, that there is no facet hypertrophy or collapse, or the neuroforamen is very, very collapsed. Because I don't want to injure the nerve on my way in. And also, I will select a case that there is no need for extensive decompression, because in my hands, doing extensive decompression with a scope will definitely slow me down. And I even discussed that with a very, very experienced surgeon from Korea that only does endoscopic. And I asked him, how long will it take him to do a unilateral approach for bilateral decompression, and he told me that it takes him like 90 minutes to do one level. And I believe that most of us can do a single level through the tube much faster than that. So I think that there are some limitations when you need to do a lot of bony work and if you decide to use the endoscope. So these are the cases that I believe they're ideal. And so my thoughts is that it's not a general purpose technique, at least with the technology that we currently have available, but it definitely has advantages for selected cases. And I think there is huge space for innovation. I probably need to go to Ben Rappaport and discuss, my frustrations with the technique and see what ideas he has on how to improve the technique. And finally, I'd like to thank Dr. Yu from Connecticut, Dr. Rutten from Germany, and our own Dr. Jenkins for helping me through this course of adopting endoscopic spine surgery.
Beautiful talk, Con. Really very exciting. Jeremy, do you have any comments on this?
Yeah, yeah, I have a PowerPoint ready. Should I share my screen?
You have a PowerPoint on the comments or your presentation?
My presentation, yeah. My comments will be
let's see if there are
integrated.
comments first on
Yeah,
Con.
no, I mean, I thought that was an outstanding talk, and I think Khan deserves great recognition for being a trailblazer for many years in this field. And I think it's exciting, and I like those case demonstrations. And but my elaborated response is in my PowerPoint response.
Good. Con, what about using more than one endoscope at the same time? I understand the exposure is limited, but why not just use two? And even with through separate ports and separate incisions.
That's a very good idea. I haven't thought about it, but that's actually a very, very good idea.
Who knows if it's a good idea, but it seems that you're so limited by the exposure and the single port that it might be of interest.
I mean, in the evolution of endoscopic spine surgery, the last few years, biportal endoscopy has really taken off. I mean, for me, if I had to do an endoscopic case today, I would do it biportal because you have one video camera and one working channel, and that's gaining a lot of steam. I think uniportal is even more ultra minimally invasive than biportal, but there is a lot of traction on biportal now.
Is Reed DeLacy here? I don't know if Reed is also an expert in minimally invasive spine procedures, though through different technology.
If I could comment on that biportal issue, that is how we used to do thoracoscopic surgery. We actually used to have 4 portals to do thoracoscopic work, because for that very reason, you have one person manning the camera, one person manning 2 retractors, and then so the first person mans the camera and the grasper, and the other person keeps the tissues out of the way. It's a workflow issue, and it's something that you can get used to, and that's why biportal is fairly popular for that very reason. It gives you two, and it's a workflow issue you have to get used to.
Great.
Am I
You are.
set up in normal display mode, or do I need to swap the presenter and slideshow view?
No, you're good.
Looks good.
Okay. All right, great. So good morning, everyone. First of all, again, Con, great talk, and I hope you continue trailblazing as you've done the last few years. I'm going to kind of provide somewhat of a counter argument. The typo in the talk for this morning was endoscopic spine surgery. The future was the talk, but actually there's supposed to be a question mark at the end in a debate fashion. No relevant disclosures. Here's why I haven't jumped yet onto the endoscopic train. I think a lot of people like to portray the endoscopic evolution compared to a metrics tube as the picture on the left versus the picture on the right. But of course, in reality, that's not really, we're not comparing apples to apples here. We're comparing, a very small incision compared to a even smaller incision. And I think the other kind of debate point I've heard is like it's going from an open hernia repair to a laparoscopic hernia repair, but really in reality, it's like making one of these blue dots a little smaller. It's not revolutionizing what we're already doing with the metrics tube. And here's some math. So if you're doing biportal endoscopy, you're doing 2 8mm incisions, and a metrics tube incision is about 16, sometimes 18 millimeters. Some people use 22, but I mean, usually we're using 16 or 18mm tubes. So I'm not so sure it's that much less invasive than what we're doing already with a metrics tube. The other thing is, I don't like wet socks. I don't know if anybody's seen these endoscopic cases, especially, I don't know, Con, if this is true for uniportal, but for biportal, you're under continuous irrigation the whole time, going through 3 liters of these 1 liter bags. And by the end of the case, the water trickles its way down on the floor, and your socks and shoes get wet, at least in my experience. But also, even when I watch Con's amazing videos, I feel like the picture on the left is uniportal endoscopy and the picture on the right is biportal endoscopy. I still have a lot of trouble getting the visualization I want to know that I'm being safe. And there's a very viral video on Instagram right now of a endoscopic spine surgery case where someone takes a bite with a kerosene, and I don't know how to embed, so my tech savviness is low, but I did want to present it here. And of course, complications can happen, open metrics or endoscopy, but it's a picture of a bite with an endoscope where a kerosene takes a bite and there's a durotomy and a nerve root comes flying out, and then you see it come out and coil into a ball. And it's like, it's a scary video because you never want to see that in any spine case, but especially you don't want to see that on an endoscopic spine case, because there's really, I mean, you're going to, abort and open up and get the durotomy and tuck the nerve root in, but it's, seeing that video is traumatizing. But I like the good visualization better, and I think your incision's smaller, but your visualization is more poor. Now, the more you do it, the better you get. There's no question about it. And I'm sure Con will say his first 10 cases were nowhere near the comfort that he has now, having done so many. But it's still, I think you're taking a sacrifice of visualization with an endoscope. Even the way Con showed that video of the way you swivel your endoscope around to push and retract the nerve away, I don't even like that maneuver, because it's a little bit blind to what you're doing to the nerve. Even though I think it is safe in experienced hands like Con's. At the end of the day, I feel like I always tell patients it's not about the incision. I don't think the reason to do metrics versus open, let's say, is because of the incision size. It's because of what's going on underneath. And in this very classic picture of a metrics tube, and the way you dilate up tube by tube by tube is your muscle splitting. And everyone who's done metrics, which is most of the spine surgeons in our department, if not all, when you pull the tube out at the end of the surgery, you watch as the muscles fold back, the fascia folds back, the fat folds back, the skin folds back. Usually we're doing 1 fascial stitch and 3 superficial stitches and we're done. It's like an auto-sealing, minimally traumatic procedure. So I think that either way, you are protecting the underlying support system to the spine of muscles and ligaments and bone. And so it's like, I'm not sure how much we're accomplishing with the endoscope. Here's an example of someone who had a left-sided L5S1 microdiscectomy, and you have the pre on top and the post on the bottom. The microscope, the metrics tube is just minimally traumatic on the way in. So it's like, it's not a tremendously traumatizing experience. You see there's a little muscle edema, and this is pretty close to right after surgery. So I think that heals. This is someone with a right-sided synovial cyst. And then the analogy I'll say is it's like a drone strike instead of a carpet bomb when you go through a metrics tube. I mean, you're looking at the paraspinal muscles on the left, you're looking at them on the right, and you're really, the cyst is gone, the canal is open, and it's minimally traumatic on the way in. Kahn showed that beautiful incision of the patient. You could barely see their incision. That was for a decompression. This is for, and I'm not really going to talk about fusions today, but this is someone who had a minimally invasive TLIF, and you see the incisions are hard to see also with a metrics tube as well. And so, these are all well-healing, minimally traumatic procedures. But Kahn's going to tell you, he wrote his new children's book, rhyming book, ABC, Look at My Endoscopic Spine Surgery. But I think that, and there's good supporting literature and for really mainly non-inferiority of endoscopic versus metrics. A lot of the studies show endoscopic versus traditional open, and I would argue that I agree that it's less invasive. I haven't really seen any showing endoscopic versus metrics tube and tremendously different outcomes. This is a very similar to what Kahn did, so I'm happy we think about things similarly. Probably, I think similarly to Kahn because he was very involved in training me. So tubular decompressions on a far lateral approach. We put the metrics tube down, and either we're doing zero bone work, if you can kind of dock and go right onto the herniation, or sometimes the way I've evolved, I used to start bottom up. So if the disc is here, I would start at the bottom TP pedicle junction and find the disc, kind of a Cambin's triangle kind of thing, and get the disc. I have recently evolved, recently being the last 2 years, starting from top down. So I actually dock the tube right here. And I'll typically either not drill, or I usually like to drill 1 or 2 millimeters of the lateral aspect of the pars. And that allows me to see ligamentum flavum. I put a little hook under. And the reason I do it this way now is because I identify the nerve from the very beginning of the procedure. And so I could see the nerve that's compressed and squashed into this pedicle. So at least we know where the nerve is. And I find it much more comfortable because then you just need to look underneath and get the herniation out. But the trauma is so minimal and the bone work is so minimal that it's, I guess the argument on the tubular decompression is even for a far lateral, which I think I would see it as probably the best indication for an endoscopic operation. And I think Kahn would agree with that. I think it's, with a metrics tube, it's a great operation for a far lateral. And then a unilateral microdiscectomy, the work we're doing, I mean, it's really in this zone right here. And that's where we're docking, that's where we're drilling. We're getting enough drilling to get the ligamentum flavum, to peel down the ligamentum flavum, to do our foraminotomy or a microdiscectomy or laminotomy. And then for a tubular decompression or a ULBD, the unilateral laminotomy, let's say we're starting on this side, typically we're going to start here, and then we'll take the top of L5, let's say, and then we'll rotate the patient away, angle the tube, and go to the contralateral side. So I think that these can all be done very well with great visualization with a metrics tube. Here's, I think, a great example, and as is the next slide, of my critique of endoscopic spine surgery. If you look at this review article on endoscopic spine surgery, it's a great article, great evidence, great review. And this, of course, keep in mind that anytime you're putting a picture into a paper, it's a nice radiographic demonstration of what you're trying to show. And I would argue that this is a great job with an endoscope, that this clearly looks better after surgery than it does before. But when you're trying to do one surgery for a patient in an ideal world, and you want to get it right the first time, I actually don't love the postoperative MRI because there's still facet hypertrophy and there's still lateral recess stenosis on both sides. Here and here, I think that this patient, how do I know? I would think they probably still have some symptoms from L5 compression because there's lateral recess stenosis on both sides. So it's great that you could do this decompression and make it look better with an endoscope. But I actually think part of the the advantage of a metrics tube is you can do appropriate visualization and make sure that you have bilateral decompression on both sides, and not leave it to this potentially not completely decompressed state, as in this picture. Here's a patient who's referred to me for persistent right C7 symptoms after a foraminotomy, and you can barely see the foraminotomy, but it's right here. And I would argue that's not really an adequate decompression. And so we ended up taking the patient back, and it's not the end of the world, and there isn't a lot of scar tissue after an endoscope, but we ended up taking, essentially on a foraminotomy, which, I have a foraminotomy today, you have to get to the lateral aspect of the pedicle to know that you're at the lateral aspect of the foramen, and I think this is an inadequate decompression. And so we ended up taking the patient back and just did this, and the patient was fine. So tubular decompression, I would say, it's a must in the repertoire. It's an amazing surgery. I think it's very easy on the surgeon because you see things beautifully and clearly in front of you. Very easy on the patient. And the last time, I guess I'll get to this in a later point. It's an ambulatory procedure. Whether it's a ULBD, ipsilateral decompression, far lateral, it's still ambulatory, and they're still going home a few hours after surgery. It's very easy to get oriented. And it's the same approach as we've all been trained in. If you get a CSF leak, it's never easy through a tube, but you can repair one. And it's quite rare to get patient complaints of post-operative pain. So I guess that's my underlying theme, is this metrics decompression works so well. I don't know if I've ever had a patient ask for an opioid refill, for example, after a metrics decompression. Some people take 0, some people take a day or 2. Certainly nobody's taking more than a couple of days of painkillers, because it's just not that painful of a procedure in our repertoire in our spine. So in conclusion, endoscopic decompressions, I don't want to be confused as a hater, because I think it's an excellent option in a surgeon's armamentarium. Invasiveness, it is an evolution in invasiveness, and if you go open traditional to metrics tube to endoscopic, it is less invasive. The question is the juice worth the squeeze? And is the more poor visualization an issue? And I think that if you go to any conference and any spine meeting in the country right now, there's tons of talks about endoscopic, and that's reflecting how we're all getting better at getting less invasive. So I do think there's a future in endoscopic. I would love to see it pair up with navigation in a seamless way that doesn't take more time. But so I don't want to be confused as a hater, but I have not jumped on the train yet because I have not been sold yet on its advantages personally. I think at the end of the day, meticulous attention to detail, ensuring an adequate decompression, and making it a one and done for the patient. You can make an argument, okay, if we don't get it, it's not a big deal because it's a quick surgery and it's so minimally traumatic. But at the end of the day, if a patient is going to arrange their work schedule and get their family in to help take care of them and undergo anesthesia, you want it to be a one and done, ideally, and not have them come back for another surgery. This is a right-sided L5-S1 disc herniation that I saw recently, and the argument I would make here is that whether you do this open, metrics, or endoscopic, this patient's going to be very happy if you do a good job and if you free up that right S1 nerve. So, at the end of the day, I think the most important thing is to do a great job in surgery and whatever is in your comfort zone, knowing that you're going to get the job done in a way that alleviates the pain. And of course, it's great to be really, really ridiculously good with metrics tubes also. So thank you for your attention, and happy to take any questions.
Hey, Dr. Steinberger, it's Alex. Really enjoyed the talk. Obviously, all of us have our inherent biases. I was at a course this weekend with a few pre-experienced endoscopic spine surgeons, and their argument from a resident standpoint is that in the next 5-10 years, it's going to be imperative that all residents at least have, or all trainees coming out have some basal level of endoscopic abilities, not just from a marketing standpoint, but just in terms of providing their patients with every possible avenue, similar to how metrics was maybe a decade or two ago. Just wanted to hear your perspective on it. If you think there's going to be a necessary role in spine training and resident education in the next 5-10 years, since we've seen these procedures and these techniques really become expanded.
So is there a role in training? 100%, and you should scrub on any endoscopic case you could get your hands on, because this is an area that's increasing exponentially. Like 5 years ago, I think there were very few talks on endoscopic spine surgery in conferences, and now it's like 1/6 of the recent Society of Minimally Invasive Spine Surgery meeting was a whole section on endoscopic. So I agree that you have to get your hands on it, and the more comfort you have with it, the better you'll be at it, and the more quickly you will adopt it.
So Alex, to your point, many cases, as we have seen, can be done equally well with either the metrics or the endoscope, but the endoscope requires some more preparation. We need to have the tower, we need to have the endoscope in the room. So there are some, let's say, gray zone cases that we default to using the metrics currently, but if there is more, interest from the residents, we can definitely try to do these cases with the endoscope for you to gain exposure to that.
Thanks,
I wanted to make
oh, sorry, go ahead.
if you can finish, Alex, if you want to.
Yeah, sorry. I was just gonna ask a quick follow-up because I was actually thinking about this during Dr. Steinberger's talk, just in terms of cost effectiveness and and feasibility, right? Like you mentioned, there are a lot of disposables that you need in an endoscopic case, right? And one would argue for a metrics decompression, the cost from a hospital system standpoint is pretty low, right? So I guess the counter argument is, how do you justify the cost in terms of scalability, right? For say a simple decompression of the actual cost of the materials for endoscopic case versus the relatively low cost for a metrics case.
Maybe we can look into that, but the disposables are basically the drill bits and the cauteries. Okay, so I don't know what is the price difference between the endoscopic ones and the ones that we use for open, but we can definitely look into that.
I think Alex, a lot of hospitals have the equipment already. Like it's not like you're buying a new video, like you hooking up to the stores. I think not stores. What's the is it store, the whatever, like a lot of hospitals have them already. So there is some disposables, and I think it is more expensive, but I don't think it's a good question. You got to look at the cost analysis, but I don't think it's such a discrepancy.
All right, so my comments are, first of all, great talks by both of you. It's really great that we have you both trailblazing in the minimally invasive space. I think it's very important for resident education, and I'm glad our residents get experience in it. I think my personal practice tends to align with more of Dr. Steinberger's views, but I do see a role for endoscopic, and it certainly is growing. I haven't seen any data to show it's better, and until it does, a lot of us will probably not move the needle. And I do agree with the incision side that the two endoscopic things will add up to be a metrics. I think my main curiosity, and maybe Con, you can address this, is, we talk about the inside out from intralaminar approach or outside in far lateral approach to the foramen. And there are times where we choose the inside out, but we also want to do a little bit of work outside in. So have you ever thought about doing certain parts of the procedure, let's say some multi-level with a metrics, from the inside out, and then using, if you need to do a little far lateral on one of the levels, that you use the endoscope in addition from a separate incision or same incision?
Yeah, I think I've done a couple of cases where I used metrics for interlaminar because I could do the bone work much, much faster, but there might have been like foraminal stenosis at a different level, and using the endoscope for that. I've done a couple of cases. That's a very good point, yeah.
Great, I'm gonna call you when I need it.
I have one comment, that both Jeremy and Khan both mentioned that there are limits to what the use is. Clearly, you have a much more robust drill with a metrics or an open procedure than you do with the endoscope. So if you're going to do a lot of bony work, it will take longer. And just be a little bit more challenging on an endoscope. So that's one of the decision trees to make. The anesthesia is also not insignificant, especially in some of these older patients. And the point that the well-experienced endoscopic spine surgeon has on doing a bilateral foraminotomy, it taking 90 minutes per level, that's in the best of hands. And I will also say that many of these best of endoscopy hands are orthopedic spine surgeons who have done extensive endoscopy as part of their general orthopedics training. So they're coming into this with a lot more experience already, hence their bias towards endoscopy. But the point is, you also have to think about, especially for multi-level disease, sometimes just doing it open. I mean, you would, if you did a 3-level decompression endoscopically, in the best of hands, that's 4.5 hours of work. In metrics, that's probably 3 hours worth of work. Doing an open 2-level laminectomy for 3-level spinal stenosis, I mean, that's an hour's worth of work, and that gets that patient off the table faster. So the decision trees have to look at what's the cost of doing a different procedure versus what the alternatives are. I mean, we always do a risk-benefit alternative discussion with the patients, and that's a discussion you have to have with yourself before you have it with the patient.
I realize I forgot to mention another risk of endoscopic spine surgery. So you have constant irrigation of fluid, and you need to make sure that the pressure of the irrigating fluid is below the diastolic pressure. If you go higher with the irrigation, then the fluid can start dissecting in the epidural space. And in the past, there were cases that they had like spinal cord compression from fluid accumulating in the epidural space. So we always, when we irrigate, I always ask the anesthesia, what's the diastolic pressure? And I make sure that we're like 5 to 10 millimeters below the diastolic pressure in our irrigation pressure.
Con,
One more question.
Con, you
Go
may
ahead.
have mentioned this. Is it really that much longer? Because I think that's a big factor. Also getting back to Alex's point of cost. If you're using an OR for twice as long, that's a cost.
It depends on the case, because for some cases, actually, it's much faster. So that's why we usually use that for very focal pathology. So I don't do the unilateral approach for bilateral decompression, because it will take me like 90 minutes or 2 hours, while doing it with all the metrics will be 1/3 of that time. But for a foraminal disc herniation, I can be done much faster with the endoscope versus the tube.
I see.
It depends on the case.
I had a follow-up question. So it's interesting for all of us to know, in your evolution, what percentage of your non-fusion cases are you doing with the endoscope versus metrics? Because you obviously do both, and you just happen to take the endoscopic argument for today's debate. And is that number increasing or decreasing?
So it decreased over the years. So in the past, I used to do many more endoscopic cases than I do now. Part of it is because my practice also changed a little bit. I get a little bit more complex cases. But for discectomy, honestly, I use any of the 3 techniques. I might use a McCallum retractors for a very skinny patient if I need to move very fast, or if there's anything like a migrating fragment or some kind of abnormal anatomy. I would like to have this mini open technique to fully orient myself and have an increased angle to work inside the canal. I use the metrics, and for a foraminal disc, I will strongly consider using the endoscope. So I use any of the 3 techniques, and I think there is a role for all of them.
So I think that's very interesting. Even when someone who has a skill set, the number of cases which are perfect for it is very selective. There may be some people out there doing all the cases with it, but I think your experience is probably more reflective of what the rest of us would do if we had endoscopic experience.
Are there any comparative studies looking at procedure time or complication risk between 2 techniques?
Yeah, so most of them are non-inferiority studies that, you have equal results. And some of them, I mean, there was a recent one about the cost effectiveness, and they were saying that for the metrics, the cost was 4,500 euros, while for the endoscopic was 41. So it was very, very small difference, which I don't know if we can really trust it or generalize that. So we're talking about small differences.
I think that would be an important study to do in the US, since the cost structure here is very different from in Europe. That, if you guys are doing enough of them, you could potentially do that analysis.
Yeah, the issue is also that in the US, there are different like models. There are some companies that they will ask the hospital to do like a capital purchase of all the equipment. There are others that they bring the equipment in and they rely on the disposables. So there are, you know, different business models that I don't know how we can combine them together.
Well, thank you guys. This is a really useful debate, and I think it mirrors a lot of the open versus minimally invasive debates we have across the various subspecialties in neurosurgery. So thank you guys for doing this today. Does anyone have any further comments or questions?
It's just interesting to call metrics the open in the debate, because that used to be the minimally invasive.
Minimally invasive versus moderately invasive surgery. All right, well, thank you all for joining. Great grad rounds today, and I'll see you next week.